All right, everybody. I had some questions about the quiz next week. I know this is all new to most of us, so you will have a quiz next week. Okay, it's going to be kind of it will be the same format, multiple choice, 5 questions like you had in class. Um, I will actually what I think I'm going to do right now. If this changes, I'll let you know. But my plan is to actually have you go through Respondus like you did for your test and take the quiz. You'll have your 10 minutes and then you'll just come to class afterwards. I was thinking about doing Google Meet through the quiz, but the problem is with Respondus, you can't do both. It won't allow you to open up any other windows. So that will be like what the quiz is like. So like I said, I'll just have it where you come on in to Google Meet when you're finished with your quiz and you'll get 10 minutes, okay? And that will be in Moodle through Respondus, okay? Any other questions? No, are we good? You can chat or talk, whichever. Okay. So yes, the quiz will be at 9 o'clock and you'll have from 9 to 9:10 and then I'll start lecture at 9:10. Okay, any other questions? All right, are y'all able to hear me okay? Is it streaming all right? Any concerns?
No, it sounds good.
Okay, thank you. The quiz will be on what we're covering next week, which will be anxiety, the anxiety chapter. Okay. All righty. So I'm just gonna kind of don't forget to go in and do attendance in Moodle if you haven't already. Okay. Just so I can see that you were here. All right. With cocaine, I don't spend a lot of time on. I find that we do get a lot of patients that come in and they have like history of cocaine or they're dependent on cocaine. Cocaine, though, is not a drug that has to be medically detoxed. Okay. The big thing with cocaine, they get such a rush from it. And then afterwards, it's this extreme letdown. They start getting irritable, very depressed. It usually affects their sleeping levels because of the norepi problems with lowering the norepi, and they start having problems with that. And of course, they're going to crave more. So that's kind of the problem with cocaine is they use and then they want to use some more like 15 to 30 minutes after because it felt so good. Like I said, it has not been proven that it's physically addictive, but it is clear that the users experience a serious psychological addiction. And usually these people get very, very depressed, okay? It's one of those things hard to know. Did the depression come before or after, right? But like I said, the biggest thing to note is that they don't need to be hospitalized to detox from cocaine. Okay. They do find too long-term use of cocaine usually leads to panic attacks and anxiety disorders. This just kind of shows a little biological response to cocaine with the dopamine. And we know that dopamine, what does that equal? That's going to equal that psychosis. So they usually do become psychotic with cocaine use, especially when they're going through a cocaine rush. Okay, long term, it is going to deplete that dopamine. And what do we see with the depletion of dopamine? Anyone? So this is going to show like Parkinson's signs. Uh-oh, somebody says that. Are y'all seeing the PowerPoint?
Yes.
I can see it.
I can see it.
Okay. All right. Thank you. Somebody said they couldn't see it. All right. Okay. Thank you. So yes, that Parkinson's. And if you've ever if you ever see somebody that has really abused cocaine, it is kind of interesting because you do start to see that shuffling gait and things of that nature. That mask-like face we've talked about. All right. Other stimulants I just like to kind of touch on because, yeah, you can see this, you know, it's usually going to be that they have a history of it or maybe they're currently addicted. But amphetamines, of course, these are stimulants that act on the CNS and peripheral nervous system. So example of this is like Ritalin. I really have found that, and I went to a conference, a nursing conference a couple of years ago, and they talked a lot about how amphetamines were just increasing in rate of abuse. And I really think that's true because I hear a lot of times somebody will say, oh, I took my friend's Adderall to stay up all night to study. Like, that is not good. Do not do that. This actually blocks norepinephrine, dopamine. It doesn't have as strong as an effect on serotonin like as cocaine does, but it's still problematic. So, you know, this is not something that you want to become addicted to. Okay, and I do think that we are kind of seeing some misuse of amphetamines. Methamphetamines, of course, this is like your meth, speed, crystal meth. It's a potent CNS stimulant that releases a lot of dopamine. So people like it because, especially if they want to kind of be psychotic, you know, it might be fun for them, I guess. I don't know. Never been psychotic. I hope that never happens. But anyways, it is highly addictive, of course. It can be, and most of these drugs can almost be used in any way, usually smoked, snorted, orally ingested, or injected. It causes a rush, kind of like cocaine does. If they do take it orally or snort it, they have a long-lasting high instead of that rush, and it can be as long as like half of a day long. So it's very cheap. So of course, if anybody has seen Breaking Bad, you know, that was kind of the big meth scene that was going on. I think that was it in the 90s? I don't know. Hopefully 2000s. But anyways, you don't hear about it quite as much as we used to. But of course, it's still out there. And then your ecstasy, this is kind of more of a club drug. People usually, you don't really hear a lot of people addicted to ecstasy. They usually use it more like I said, when they're going to raves or clubs, things like that. The biggest thing with ecstasy, if it's used in high doses, they can go into malignant hyperthermia, which is very scary, and we have to watch for. Next, I think I did skip a few of these, and I'm gonna talk about those when the time at the end. But benzodiazepines, like I said, I like to talk about this because this is your other big drug. You know, this is your big classification of drugs, like Ativan, Valium, Xanax, Librium, Cirax. Those are kind of old guys, but you still hear of them sometimes. Klonopin. So these drugs, when do we usually get them? They're very overprescribed by doctors. And this is like one of my pet peeves. If you had me in clinical, you know that. So with the benzodiazepines, they're very, very, very addicting. And usually people go to their PCP and say they have anxiety, and doctor's like, oh, here's a good old benzo, right? And of course, we see the tolerance, we see the addiction. So you have to be very, very careful there. Same thing, it is a dangerous physical detox that they do need to be in the medical setting to be detoxed. And they usually are are going to show some signs like they're usually very, very anxious because obviously they've been using benzos for a long time for anxiety and they've become so tolerant. So they usually have a lot of anxiety rebound, sensory excitements, autonomic rebound with hypertension, tachycardia, sweating, things of that nature. They'll have nightmares, cognitive excitation, delirium, depersonalization sometimes they'll go into hallucinations. And of course, the biggest thing is we're going to see the tremors, but we don't want them to seize. And like I said, we know with benzodiazepines, they use them to help with seizures as well. And so that's why you're not just going to get somebody off. The tolerance will go up and up and up. But it will actually, I'm sorry, I saw a little chat and I'll talk about that in a minute. But I'm sorry, I kind of lost my train of thought. Let's see. Oh, with the benzos with tolerance, they'll take more and more to get the same effect. And as we know, in time, they're just overusing it. And if they get off cold turkey, what are they going to do? They're going to seize. Okay. So that's why same thing with benzos. As for, as we talked about with alcohol, they're going to be on a benzo taper. So I know you're kind of like, well, we're getting them off benzos and we're putting them on a benzo taper. Same thing though, we're getting them off a little slowly so they don't seize on us. Okay. Opiates. Opiates is one of those that, like I said, lots of times, you know, when people think of detoxing, they think of opiate abuse, and especially heroin. That's the big one that we always hear about. Like I said with this, with opiates, and let me give some examples. You know, we have the Lortab, the codeine, we have orals, and then fentanyl, heroin, morphine, oxycodone. So a lot of these we do find can be abused. It's the same thing because the tolerance does build up. So if somebody's in pain, then they'll, you know, have to use a little more and more and more until maybe they're overusing it. The good thing is we do have something that we can use to reverse the effects of opiates, and that is Narcan. So, you know, we do see if you start to see like respiratory depression because somebody has used too much, Narcan is a great drug, and now they have it, of course, in nasal form that they can give it very quickly. But it's nice to have that reversal agent. Something to think about too, and I didn't tell y'all this, but with benzos, there's a reversal agent as well. It's called Ramazicon. Okay. And actually, I'm going to spell it out for you in the chat because it's one of those things I have to look at. All right. So it's called Ramazicon, and that is the reversal treatment for benzodiazepines. All right. So some, like I said, with opiates, they just feel like crap. It's like a really bad flu. So usually they don't get through the detox because they crave so much as part of the detox that they're going to use again. Okay. Lots of times facilities aren't going to admit you to detox from opiates because of it's not considered to be something that's a medical necessity. So then they detox at home. And like I said, they'll do it for a couple hours and they feel so terrible and they're craving so much, they're just going to use again. So occasionally you'll see it, but usually they're not going to admit somebody for it unless they're coming in for something else like depression, suicidal ideations. Okay. Drugs that help treat addiction with the opiates is methadone. I'm sure you've heard about that. They usually have to go to methadone clinics. I'm not a huge fan of methadone just because I find that some people do get addicted to that. Naltrexone is another one that they use. And I can never say this. Y'all can see buprenorphine. I can't say it. But anyways, that is another one that they'll use as well. And I'm trying to think of the other name for it, and it's not coming to me right now. but you do have to definitely be careful, especially with methadone and the buprenorphine. Okay. I did want to kind of tell a little story here about a patient that we had on St. Clair. She actually came over from the emergency room, like where we get our patients, and she had OD'd on opiates. I don't think they were sure which type of opiates, but they knew opiates. And they had actually Narcaned her in the ER. So, you know, they had the IV in her. They gave her Narcan in the ER because she had respiratory depression. And then a couple hours later, they're sending her over to us. And that's always something you have to look out for with the opiates is respiratory depression. So I get this patient and I am doing her mission assessment and I am just getting her vitals. Like she's very sleepy, getting her vitals. And while she's sitting in the chair, thank you, it was Subutex. Somebody just, the buprenorphine, it's Subutex. Thank you. It wasn't coming to me. I'm sorry. So with this patient, she's sitting there and I'm counting her respirations, and no lie, with these patients, you got to count them for the full minute because like you're at 30 seconds and they're maybe till at 3 respirations. You're like, holy crap. This patient was like 5 breaths per minute. And so obviously she's definitely going into has respiratory depression. So we had to actually give her some more Narcan. Has anybody given Narcan? It's such a miracle drug. It's amazing. The problem with Narcan is it has a very short half-life. So you have somebody on an opiate with a long half-life and you Narcan, and that was the problem with this patient. In the ER, they gave her Narcan, but lots of times you're going to have to give Narcan a couple times throughout because it has that short half-life. Does that make sense to everybody? So we had a Narcaner again, and it is amazing. You have somebody's like respiratory depression. They're about to die. You shoot the Narcan in, and they just like wake up like, hey, what's up? Nothing you know, it's really amazing to see if you've ever seen it. But like I said, you have to watch that person because most likely you're going to have to Narcan them a couple times. And I make note of this. That patient, if I didn't check her vital signs before she went to bed, she would have died. She would have went to bed, and nobody was checking her vitals. You know, when they're on the psych ward, we don't check vitals that often. She would have went in, had respiratory depression until she wasn't breathing anymore, and she would have died. So you have to be very cautious with these patients. Okay. So marijuana, I mean, what do I say about marijuana? The biggest thing I think you need to know about marijuana is it stays in the system a long time. Okay. So, I say that because with opiates and other things, of course, it's hours. So when I do a urine drug screen on someone, you know, it has to be in their system for a couple hours. Or, you know, it's not gonna, a day later or even 12 hours later, an opiate isn't going to show up as a positive. But of course, marijuana can stay a positive up until like, I think like over a month because it's stored in fat tissue. And so it stays in the system a lot longer. So that's just something I always say, you know, they might say, I haven't smoked marijuana for a month. And that could definitely be true. It's still going to show up as a positive because of this. Of course, we know that a lot of places are making it medically necessary. Or they can get a prescription. They can have it for medical necessity, I'm sorry. Different things that they find that it actually helps with. The THC the THC component of cannabis, they find helps with epilepsy. Of course, it helps with pain. They give it to cancer patients. It also helps with appetite. you know, they always talk about people on marijuana, they get the munchies. Well, it does it. It's like an appetite enhancer. And so they have found that that works really good for people that have anorexia, especially like cancer patients, that the chemo just kind of gets rid of that. They have found that it works really good with muscle spasms with people that have like cerebral palsy and things of that nature. So I do find that I think that this will not be an illicit drug much longer, but you know, it still is. So we still have to look at it that way. With this, and I don't think, I'm sorry, I know I wanted to see if I had synthetic marijuana. I want to talk real quick about synthetic marijuana right here. So synthetic marijuana, you have probably heard of that, okay? It's called a bunch of different things. People call it spice. It has different names as well. Fire and ice. I know I hear a lot of potpourri. It's usually found at gas stations, okay? It's considered 10 times more potent than marijuana, and it's any Joe down the street can actually go and buy it. It used to be a lot more prevalent because you were able to buy it at gas stations, the raw shop, all kinds of different places. They actually did make it illegal, but the problem is it is synthetic. So like I said, it can be made by anybody, you know, kind of like meth. It's kind of scary. And they can use gasoline, they can use rat poison, they can use all kinds of different substances with the THC, okay? And it actually causes a lot of long-term effects. Probably, I would say within the last 10 years, we have seen definitely a decrease, but we still see it. It's scary because they don't have like a test to show that it's positive, because we don't even know what people have put in the substance that make it. It usually causes people to become very psychotic, and we don't know if that psychosis is going to leave them. I will tell you, probably 5 to 10 years ago, we had an influx, and it was usually, and I think it was just because of the age, but we usually had like, it was younger, like 18 to 20-year-olds that would come in and just psychotic and violent, very violent and aggressive. And we actually were thinking that at first it was their first psychotic break, schizophrenia, because it kind of appeared like that. And then here we end up finding out that it's this potpourri that they're selling. So like I said, they usually get very psychotic. Sometimes it lasts a lot longer than others. I've had people that clear up pretty quick, and then I've had people that have been in the hospital for months. And like I said, it's just a very dangerous disorder, or dangerous thing to play with. And so why do you think usually you're going to find people use this over THC? Does anybody have any ideas on the chat? It's cheaper, somebody said. Very good. Jara, and I think I'm saying that right, I'm not sure, but Jara said it doesn't show up on drug screen. That's exactly right, okay? So if you remember a couple years ago, I think it was when, probably shouldn't say this, but I think it was when Matthews was a football player at LSU. It was a group of them, actually, and they got in trouble for synthetic marijuana. What lots of people will tell me is they use it because it doesn't show up on a drug screen. So, you know, like LSU football, they're drug screened all the time, and they're going to be kicked off the team. Well, this will show up on drug screen, so a lot of people will go to that first. The problem is they don't understand the long-term effects it can cause. So that's always something that I'm definitely talking a lot about to my patients about. Dissociative anesthetics. This is kind of like your PCP. Ketamine. Ketamine is still used a lot like in operating rooms and things like that. But when I tell you that ketamine is a crazy drug, not something that I love, when my patients are on. It does actually cause like a separation type, a dissociative effect. And if you already have somebody that has psychiatric issues, I find when they're on ketamine and they're coming out of ketamine, they freak the heck out. Lots of times you will hear, if you're watching the news and things like that, they have started to use ketamine drips for pain, for people in severe chronic pain, and they're trying to decide if that kind of works for them. You know, there's a lot of questions there. I think we will, in the next couple of years, be hearing a lot more about ketamine drips for different procedures that they use. I actually got to talk to somebody who had a ketamine drip. I want to say she had 6 drips. She had to pay out of pocket because it wasn't covered by insurance. It was for chronic pain that she had. And we had to do so many different things at the surgery center I work with. Low lighting, low stimuli. We actually had her classical music with headphones. And it was just very, very interesting. And talking to her, she said she would never do it again, that it was terrible, that she had terrible hallucinations the whole time. She felt like people were out to get her and that kind of thing. And she would hear us talking. You know, it's a surgery center. We kind of put her in the back, but we're still busy, and she would hear us and thought we were after her, that kind of thing. So anyways, kind of interesting. Inhalants is another one that I just kind of touch on. Inhalants, we usually see this with younger people, and it's just because that's what they can get. You know, it's easy access. They can get paint, spray paint, and liquid corrector and all that kind of stuff. You can find that pretty easily, gasoline. And so, you know, you do the sniffing and it actually gets you right. So they find a lot of younger people do this. The problem is you're at a risk for sudden sniffing death, which is just where you have too much CO2 in your system, in your brain, and it can also cause like brain neurological problems, and severe, if it doesn't kill you, it can cause brain damage. All right. So nursing assessment, we're going to kind of go through this a little quick because I talked a lot about this before. But anytime you have somebody you think they might have been abusing substances, they should have a urine drug screen. Now, our patient population at the lake that comes in that's a psych patient gets a urine drug screen and a blood alcohol level. Okay, so that's always something you want to look at. Okay, like I said, we know that certain things stay in the system longer than others. So we, you know, it just kind of depends. But usually if they're abusing it, we're going to be able to see that. Talking to the patient, knowing what drugs they're using, knowing the type of alcohol, like we said, the amount, the frequency, and really important, the last use. Now, why is that important? Because obviously I want to know if my patient's going to start detoxing or not. So I need to know if their last drink was 3 hours ago or if it was 3 days ago. That's going to make a huge difference. Also, I don't think I mentioned it, just to go back for a second, but somebody with alcohol, when they can start to detox up to 4 hours, into 4 hours. So it is important to know when that last drink was, okay? And same like benzos and things, that's important. Have they had previous treatment? Have they been to rehab centers before? Is this their first time? Have psych disorders. Psych disorders are very common to co-occur with substance abuse. And that's what I was talking about, like when I started this presentation, that with substance abuse, you know, we think, you know, we can think very negatively about it, but we need to find out why. Why are they drinking? You know, that is so, or why are they using? There is usually a reason why this is happening. So it's digging, getting that rapport with the patient and finding out. We have really found, of course, you can see a lot of denial, with substance abuse. And so until somebody really is motivated to change and can admit they have a problem, they probably shouldn't be getting treatment. And I know that sounds harsh, but you've seen a lot of reality shows like intervention and things of that nature, which I think are cool for you to see what an intervention would be like. But a problem that I really see with that, when you have people forcing you to get help and you don't want it yourself, you're usually not going to change and you're going to go back and relapse because you don't see what the point is. So that's really something that's important to look at. At first, I remember when I started working at the lake, there was a doctor and he did most of the chemical dependency stuff. And if they weren't ready to change and wanted to change their life and get clean, he would discharge them day one, day two. And people would be like, God, that's so terrible. You know, they had a chance. They don't have a chance. If they don't want to change and they're going to go use again, let's give the bed to somebody that does want to change. Okay, so those are things you kind of need to look at. Transference and codependence is something I want you to kind of look at in the book. These are different emotional reactions or behaviors that happen to family and people that have been around abusers for a long period of time. It's almost like they do things they normally wouldn't do because of the situation they're in. So for example, let's say somebody has a son that is addicted to heroin. They might bring them to go get the heroin and pay for it because they don't want them maybe being a prostitute or something for money for the heroin, if that makes sense. So you do things that you never think you would do to try to protect your family, but you're actually enabling. So just make sure you read up on that in your book a lot, okay? It's their definitions and they give examples, and I think the examples are pretty good. So different diagnosis that we would kind of look at. Of course, ineffective denial is a huge one. Others are going to be dependent on the substance. You know, I would say a big one that sorry, my dogs are fighting. One that I would always say, when in doubt, ineffective coping. Okay, most of these people that are using, they're doing it because they have ineffective coping skills. You know, where I might go for a walk when I get really stressed, they might pick up some liquor. Okay. So, and that is something that they learn, that they have learned over time. So that is something we help break, but that is one thing I definitely would, I always say, when in doubt, ineffective coping. The other one was ineffective denial. So with interventions, same thing. I've kind of gone over some of this. They all have pharmacological modalities depending on the drug. Like I said, we talked about alcohol. We talked about benzos because those are the big ones that we're going to see and have to treat in the hospital. So you need to be aware of that. ASEs, we already talked about that. That's the scale. Lots of times if a patient comes in and the doctor, maybe they have a positive UDS and the doctor's unsure if they're going to actually be detoxing or not, they'll do ASEs before they even put them on benzo taper because they want to check and see if their numbers are high and showing signs of detox. Okay. 12-step programs, I'm sure you've heard about these AA meetings, things of that nature. They find that this really works good and gives them someone to be accountable to. So in the long term, they find that 12-step programs work very well for these patients. Of course, cognitive behavioral therapy, education groups, group therapy, family therapy. Family is so important within all this because you do become codependent and an enabler. And lots of times they don't even realize that. They just feel like they're helping, and sometimes they're hurting worse than they're helping. So that's something that needs to be looked into. And relapse prevention. I always say the biggest thing, when somebody comes into acute care setting, they're coming in to actually get detoxed. Okay. When somebody's detoxing, they feel so bad that lots of times they can't go to groups and focus on that psychological because we're so worried about the physiological right now. Okay. So they're there 3 to 5 days. During those times, they're going to be detoxing. So the next step is really to get them in a rehab, a 28-day program or something of that nature. I will say something we don't always consider, but 28-day programs are not cheap. Insurance usually doesn't cover it. I know of one in the state of Louisiana that's a state program, and it takes a long time to get into. So here they go ahead, they detox at your facility, and they're not going to keep you till you go to rehab. So guess what? You're sent home, and what's probably going to happen? You're going to start using again before you go to rehab, right? So then you have to be detoxed again before you get in that rehab. So it's a vicious cycle, and it really sucks to see. And hopefully that's something we can work on. But most rehab facilities, I will just tell you, we're talking for a 28-day program about $10,000. So this is not cheap. And usually people don't go to one rehab and are cured, right? So it's a lot. It's a big toll, not only on the person, but on the family. So that's something to think about as well. These, y'all can kind of read through these. Of course, rapport is going to be very hard to develop usually with these patients. They feel very judged. And a lot of that comes from our culture, like I said. These are actually some of the only patients that we actually have to kind of, let me think of kind of the right word. They have to be confronted. And that can be kind of hard. And we have to be careful as nurses to do that because we build this great rapport and we don't want to destroy that. But if they are not confronted and understand that, hey, I have a problem, then are they going to get the help they need? Absolutely not. Okay. So definitely, and this is another one, you know, I always say it's good to reflect before you have a patient with this to see how your feelings are. Are you going to change the way that you treat this patient because they use and maybe you don't understand? So that's something to think about as well. Okay. We hear about interventions. These happen, you know, usually to people that don't think they're having problems. But I always say if you ever watch a show Intervention, it's great to, of course, the whole hour is not the intervention. It's usually like 10 or 15 minutes. But it's good to see what an intervention looks like. So usually it's usually someone like controlling the meeting, like a social worker or something, and then family members, and they talk about it for a couple days or whatnot, and then then they'll plan to bring the patient in and confront them. Okay, like I said, though, you really need to have a professional to do this. I just talk about harm reduction information as nurses. This is something we're supposed to do. So for example, when we see maybe a lot of STDs at a high school or a lot of pregnancies, a harm reduction tool would be to go and promote safe sex and give out condoms. Not everybody agrees with that, but as a nurse, harm reduction is like one of our parts of our role, if you will. Okay, so something with drug use that a lot of people don't necessarily agree with, and believe me, it's not my first, it wouldn't be my first choice, but teach harm reduction techniques to people maybe that are IV drug users so they don't get hepatitis or HIV. So actually they have like clean needle programs that some places you can actually, if you're a drug addict, you can actually bring in your needles and they'll give you new needles. As a nurse, maybe it would be if they don't have transportation and you know they're going to continue to use, then teaching them how to clean their needles, you know, and believe me, like that's not the first thing I want to do, but it's better than them contracting a HIV or hepatitis, right? So those are some things as nurses sometimes we have to do as well. And then I just always, with this lecture, I like to talk about chemical dependency in professional nurses. You all are working so hard to get your nursing license, right? And you do not want to lose it as quickly as you've gotten it. We don't really think of chemical dependency being a problem, but it actually is a huge problem with nurses, 10 to 20%. And you can look at different lectures or research articles. Some thoughts are that we have easy access to drugs, you know, and that's how it can happen. It used to be, if you were caught doing any kind of substances, a positive UDS or whatnot, then your license would be taken away and you'd never get it again. Now we actually we are one of the states, and not all the states have it, but we have a actual self-admitting what am I trying to say? It's not coming to me. You can actually go to the state board and say that you have a problem with some kind of drug and that you are using. And if you self-report to them, they will actually put you through a program. And this program will help you get your license back. It won't be taken away forever. Okay. Now, if you don't self-report, and you are found out through a urine drug screen or maybe impairment at your job that you are using, then your license still can be taken away. So those are some things you kind of want to think. So we do have in Louisiana mandatory reporting laws. So it doesn't sound like the best thing in the world, but it's a lot better, like I said, than getting this license taken away that you've worked so hard for, right? I like to talk about signs and symptoms that you can see of chemical dependency in nurses. It's not always things that you think of. They're very labile at times. They have mood swings, inappropriate behavior, frequent days off, non-compliance with policies, procedure, deteriorating appearance and job performance. Their charting can be very sloppy or illegible, errors in charting, alcohol and breath. And I will tell you that in the past, we had to report a doctor for having alcohol in his breath. And so it is our legal and ethical duty as a nurse to report these things. Forgetfulness, poor judgment. Of course, if somebody's just forgetful, I'm not going to go say, well, that nurse is really forgetful. She forgot, you know, I mean, you have to have some data to back it up, of course. Sometimes they volunteer to be the med nurse where they're just giving medications to all the people in the unit. Volunteer for overtime a lot. No drug use unless prescribed following a surgery. Lots of times it's people that have gotten Lortab after surgery and started misusing it. So it's not usually what we think, okay? And then a family history. Now, why do I tell you this? It's not to pick one or two things out and say, oh, maybe they're using. You're gonna start seeing things maybe in the professional setting of people that you work with your peers. And if you start seeing some of these things, I would say it would behoove you to go to your nurse manager or supervisor and just say, hey, I'm having some concerns here, okay? It will not be anything legally against you. Like I said, ethically as a nurse, we are supposed to report these things. I always say, how would you feel if your mother was getting taken care of by someone who you smelled alcohol in their breath and you didn't say anything? Not a good thing, right? So just kind of putting that out there, it is something that we do see. So, and then lastly, co-occurring disorders I like to talk about. All co-occurring disorders or dual diagnosis, all that means is someone is diagnosed with a substance abuse and a psychiatric disorder. Okay, so major depressive disorder with alcohol use disorder. This is this is important for so many different reasons, but you know, it's kind of who knows what came first, the chicken or the egg, the drug abuse or the actual diagnosis. But a lot of people do self-medicate. So this is kind of something we definitely want to look at, and you will have a lot of patients that have co-occurring disorders. I think I read, I'm not sure if it was in this book, I think they say 20 to 30% have co-occurring disorders. I will tell you from my experience, I think it's more like 50%. I have no research on that, but I'll just tell you that I see a large portion of people that do use have co-occurring disorders. So that's definitely something to think about. I'd just like to say too that bipolar, someone that's diagnosed with bipolar in the depressed phase, they are usually substance use is more common from them than any other mental illness. So people that are bipolar in the depressed phase, you have to really watch out for that. Okay, it's pretty common. Any questions, comments? Oh, there's a few things I'm seeing after the fact. Let's see. Hannah, did I answer your questions about repeating the first two? I'm not sure what they were. Yes, okay, good. Somebody said about their patient was using synthetic, and one reason they knew was the CPK level was high, and I'm glad you stated that. So it actually breaks down muscle. So, we usually look at CPK levels, what if somebody's having a heart attack, and we expect this to be high. It can also be high with drug use. So good job with that. I'm glad you mentioned that, Alexis. Let's see, somebody said that, can you repeat what you said about the quiz? The quiz will be from 9 to 9:10 next week. I will have it on the Moodle site under Respondus for you to do. It will be just like a quiz you take in the course that we've taken in person. And then I will start lecturing at 9:10 after that, okay? It will be on the information from the reading, which will be on anxiety next week. And the recording I will post within the hour or two, okay? Any other questions? I appreciate y'all hanging with me. If you have suggestions for me, please tell me, because this is all new to me as well. This is the first time that I've taught online via Google Meet. I've had a lot of meetings, but this is the first time for that. So if you do have any